Introduction. Dr. Peter A. McCullough, MD, miles per hour, at P_McCullough, is a board-certified cardiologist who has testified before committees of the U.S. and Texas Senate regarding the treatment of COVID-19 and management of the ongoing pandemic. Dr. McCullough studies the intersection between kidney and heart disease, and is the most widely published author of scientific papers in his field. Joe Rogan and Dr. McCullough have a comprehensive discussion about COVID-19, the controversy of hydroxychloroquine, vaccination, and much more. Fear of COVID among medical professionals. Challenging each other and asking tough questions was the norm in academic medicine prior to COVID. Early in the pandemic, no one knew what to do. There was no plan in place to treat COVID-19 patients at home and prevent hospitalizations. Doctors for the first time in their lives felt that they could get the disease themselves if they saw and treated COVID patients. Dr. Peter A. McCullough. The focus became on how to protect doctors, for example, PPE, air filtration, etc., instead of how to treat patients. There are only about 500 doctors in the US who are actually treating COVID-19 properly without fear. Note, the most effective contagion control is using oronasal viral cytotherapy decontamination. The airtime and focus shouldn't have been on masks. First attempts at treatment of COVID-19. No treatment protocols emerged until McCullough's paper was released in August 2020, which triggered the release of the Home Treatment Guide by the Association of American Physicians and Surgeons, AAPS. There was insufficient time for large-scale randomized clinical trials, which take 2 to 4 years. This was a mass casualty event that required faster-paced studies. Ground rules of early studies, signal of benefit and acceptable safety. It was clear the virus was always going to require a cocktail to treat, similar to HIV, because of the 3 major components: 1. Viral replication, 2. Cytokine storm or inflammation, 3. Thrombosis. Villainization of hydroxychloroquine. Hydroxychloroquine was the most promising treatment when used early with a low toxicity rate. Evidence of the efficacy of hydroxychloroquine for SARS-CoV-1 date back to 2006. The US and other countries had the right idea to stockpile hydroxychloroquine early on in the pandemic. Early in the pandemic, AAPS sued the federal government to release the stockpile of hydroxychloroquine. There seemed to be a collusion of the FDA and federal government to prevent the release of hydroxychloroquine. Throughout the world, US, Brazil, Australia, Europe, Africa, China, there started to be stories of governments making it nearly impossible for doctors to access hydroxychloroquine. The backlash against hydroxychloroquine was extreme. The main production plant outside Taipei was mysteriously burned down. Emergency use authorization was a previously unused mechanism. The use of hydroxychloroquine was restricted to inpatient use, but as we now know, COVID treatments must be started early in diagnosis before people are too far gone. NIH trials of inpatient hydroxychloroquine use yielded neutral results: no harm, no benefit, but were administered late, underpowered, and never reviewed. We've based the entire house on hydroxychloroquine on 2 placebo-controlled, small inpatient trials that didn't have sufficient power to see an effect if indeed it was there. Dr. Peter A. McCullough. In June 2020, FDA said do not use hydroxychloroquine to treat COVID-19 full stop. Never reviewed data. There was gross academic incompetence, but a trend that academia was not receptive to treatment even amongst the top scientific journals and universities. Harvard University paper published in Lancet, since retracted. It became clear that the goal was to vaccinate our way out the pandemic, with little to no regard given to any other treatment. Suddenly in summer 2020, trials of drug treatments stopped. The 800,000 deaths we have right now, I can tell you to a 1 they've received either no or inadequate early treatment. Dr. Peter A. McCullough. Monoclonal antibodies. There is a lack of transparency about monoclonal antibodies. The US has reportedly purchased 100 million doses, with another 500 million on order, but they are still hard to find. The monoclonal antibodies were granted emergency authorization before the vaccine, with impressive results. At least one study has shown that if you prophylactically take monoclonal antibodies in the presence of others with COVID, you will reduce your risk of getting COVID. Monoclonal antibodies are safe and effective in vaccinated or unvaccinated individuals. Not everything that came out of the pandemic warp speed was bad. Early treatment is key. Monoclonal antibodies are not administered once you are inpatient, though they should be. Brief notes about ivermectin. Ivermectin is widely distributed in other places, with some efficacy. It's the first-line treatment in Japan and attributed to flattening the curves in Mexico, Peru, India. Overall, ivermectin is widely used, safe and effective. The trickiest thing about ivermectin is dosing, as opposed to hydroxychloroquine, which is more stable. Suppressing treatment to promote vaccine uptake. We've had a giant loss of life. It seems to me early on there was an intentional, very comprehensive suppression of treatment in order to promote fear, suffering, isolation, hospitalization, and death. It seemed to be completely organized and intentional in order to create acceptance for and promote mass vaccination. Dr. Peter McCullough. There is evidence of extreme collusion on the part of Pfizer, Moderna, NIH, and many more public service agencies. Moderna was working on the vaccine before the virus ever came out of the lab. A Johns Hopkins 2017 symposium called the SPARS pandemic outlined that we would face a coronavirus related to MRSA and SARS that would devastate the United States, shut down cities, induce confusion, and railroad people into mass vaccination. The average death certificate takes 6 weeks to produce. How did the media get numbers so quickly? At some point, we essentially had a COVID death scoreboard. The number of COVID-19 deaths and testing has been padded to some degree, deaths padded by underlying factors that contributed more to death than the COVID testing from duplicates. Check out COVID-19 and the Global Predators, We Are the Prey by Peter Roger Breggin and Gina Ross Breggin. This book has thousands of citations as to how this was coordinated and planned. The so-called mass formation psychosis. It's clear there are a lot of people not acting well and unable to have normal conversations and discussions about COVID-19. Mass formation psychosis, groupthink that has developed so strong, it leads to something horrific, such as mass suicides in religion, walking into gas chambers in Germany, etc. Key components of mass formation psychosis: 1. Period of isolation, lockdowns. 2. Withdrawal of things taken away people used to enjoy. 3. Incessant freeloading anxiety, constant news of deaths, tally, spread. 4. Must be a single solution offered by an entity in authority, vaccination. In mass formation psychosis, it doesn't matter the absurdity of the solution. People were so far in the trenches, they didn't want to accept the research that COVID-19 was not spread asymptomatically, it's only spread from sick person to susceptible person. Check out The United States of Fear by Tom Englert. Vaccine-related myocarditis in children. Without COVID, there is an age and gender gradient to myocarditis. It's about 80% in boys, teens, 20% in girls. A young boy is more likely to be hospitalized of myocarditis than ever be hospitalized from COVID-19 respiratory illness. The vaccines do go to the heart and get distributed. To date, we have 13,000 certified cases of myocarditis post-vaccine in children. Vigorous physical activity can trigger sudden cardiac death. Fear: 13% of myocarditis ends up with progressive heart failure. Treatment of myocarditis includes no exercise for several months, and several drugs to relieve symptoms.